Good afternoon and welcome everyone. Today's live webinar is titled Private Equity. Be careful, it ain't private anymore. We would like to thank our speakers today and our sponsor, Intrax, for joining us. And thank you for joining us, everyone. This live webinar will last 90 minutes, and at the conclusion, there will be an opportunity for questions and answers. To submit your questions, please use the Q&A feature at the bottom of your screen. For important information about today's webinar and to greet today's presenters, please use the chat feature at the bottom of your screen. I'd like to take the next few minutes to introduce our speakers, Kim Harvey-Looney and John Kelly. Kim Harvey-Looney is a partner with K&L Gates, where her practice focuses on healthcare regulatory compliance matters for hospitals, healthcare systems, outpatient facilities, post-acute care providers, and others. She has extensive experience in physician self-referral and anti-kickback regulations and other fraud and abuse statutes and regulations. Additionally, Kim assists clients with operational issues such as licensing, Medicare certification and reimbursement, certificate needs applications, and contracting issues. She's well-versed in clinical integration and related issues. She is recognized for her health law experience by Chambers USA, Best Lawyers, and Super Lawyers, and is in my hometown of Nashville, Tennessee. John Kelly is chair of Barnes & Thornburg's National Healthcare Department and Industry Practice, and a former U.S. Department of Justice healthcare and fraud prosecutor. John advises and defends companies and executives in criminal and civil government investigations involving healthcare fraud, including False Claims Act. John represents providers, hospitals, health systems, clinical labs, pharmacies, drug distributors, pharmaceutical manufacturers, medical device companies, and payers before the DOJ, HHS OIG, CMS, FDA, FBI, DEA, and other state and federal regulatory agencies. He serves as outside compliance and investigations counsel for healthcare and life sciences companies, including those subject to corporate integrity agreements, and assists in disclosures to federal and state regulatory agencies. And my name is Stephanie Haywood. I'll be serving as moderator for today's discussion. With nearly 20 years of experience in healthcare contract lifecycle management, I've held leadership roles throughout my career aimed at providing guidance on contracting best practices to mitigate compliance and financial risks within organizations. And I'm excited to be speaking and moderating this discussion today with Kim and John. Thank you both for joining us and sharing your expertise on this very important topic. Before we jump into the presentation, our speakers have prepared a couple of polling questions that we're going to review right now. So our first question really is just to get a sense of everyone's role within your organization. So if you don't mind just taking a moment to let us know your organization. Looks like we have a couple of private equity advisors, several law firms, no physicians, in-house counsel, consultants, and others. We will let the poll run for just another minute. Great. And we can go ahead and into the poll. Looks like the majority of our people joining us today are from law firms. Thank you all for joining. Our next question is really going to focus on what you'd like to learn a little bit more about. So if you are interested in learning about your level of awareness for federal agencies when a transaction of healthcare provider takes place, why regulatory agencies are increasing enforcement on private equity, what healthcare regulations apply to companies within your portfolio, or what steps PE firms should be taking during due diligence to mitigate risk. And I can tell you, because I've had an opportunity to see the presentation, that we're going to be covering all of these topics today, but let's see what everyone is most interested in learning about. So we'll let that run for just another minute. Okay, looks like most people are interested in learning what steps PE firms should take during due diligence to mitigate risk. followed closely by why regulatory agencies are increasing enforcement on private equity.
They're all pretty close, though.
Yeah, it's a tight race right there, Stephanie.
Yeah, it is.
Yeah, following with level of awareness needed for federal agencies.
Well, I tried to vote as the host. I know we're not allowed to. I wanted to listen to whatever Kim was saying. So
well, we will let you all kick it off. And with that, Kim, I'm going to turn it over to you.
Sure. Well, we have prepared an agenda kind of as our first slide. And as Stephanie said, we are pretty much going to be covering all the topics that she asked our questions about. So, just a little basic beginning, what's private equity? We want to talk about the pros and cons of PE in the healthcare industry. PE has taken a huge beating in the news. All the bad things seem to be coming out all the time. John, neither of us believe that PE is all bad or as bad sometimes as it's made out to be. There are pros of PE. Although when you read the headlines, you would think, and especially with some of the things we're going to talk about, you would think it's all cons and no pros. There is a lot of increased enforcement. We also want to kind of talk about some of the practical considerations because we think that's one of the things that most important is for people to understand maybe some things they could do. And I noticed we had quite a few people in our category of other for what your role is. If y'all want to put in the chat what you are, that might be interesting for us to know. And also, if you have any questions as we go along, please feel free to go ahead and put those in the chat, and Stephanie will try and monitor those and bring those to our attention so we can answer them as we go along. But certainly there will be time at the end to answer questions also. So kind of what is private equity? And, it is a class of capital. It is money. That's one of the things that's pretty clear that it is. It's generally invested in privately owned companies. It's not something that's traded on exchange. It is it's not venture capital. Venture capital is different because venture capital is not early stage companies, but we're going to be looking at more early stage companies that appear undervalued, underperforming, and that have been identified as having significant growth potential. So that's kind of what you're looking at, is somebody who wants to get a good return on their investment. It is more than just the money, though. I think that's kind of a big piece of it, is they feel the people that are willing to put the money in feel like they're bringing more to the table than just the money. They feel like they have the business smarts, so to speak, to improve the company's prospects and increase its value. And that is what they're doing. Doesn't always work, but there have been a lot of successful PE funds and a lot of successful PE companies. And as far as people who invest their money in the PE funds, that can be institutions, sovereign wealth funds, pension funds, high net worth individuals. John, I don't know about you, but I do not think I qualify as a high net worth individual, or at least do not have the funds I would think that I want to put in a PE fund, but they are looking at above market rates of return. So it is something that, it's been good for the economy. It is generally a typical legal structure. It's generally limited partnerships. You're going to have a general partner, and the investors are going to be limited partners. The investors are looking, as I said before, above market rate of return, and they really want like around 30%. That's a really big rate of return, but there is an inherent risk. There's a lot of risk in the investments that they're taking. And there's also, the investments are not very liquid. So you're subject to not necessarily being able to get out very quickly if you're an investor, and there is a lot of risk. The time commitment the investors are going to do, the PE funds are going to want you to invest for up to maybe a 10-year commitment and impose penalties for early withdrawal. And there might be some allowance for extension of that term, where if they start with a 5 or 7-year term and they decide that's not long enough, they might be able to tie you up for another period of time. So, it's a fairly long-term commitment for your investment. Now, the PE firms, on the other hand, they want to get their money out really within 3 to 5 years if they can, or, commitment to invest or return the uncommitted capital so that they're not tying all their money up. There is they try to segregate the transactional risk. So the PE fund, each one generally is sort of a special purpose entity. So there's not a lot of crossover between the different funds. Now, these funds have hundreds of millions of dollars in them sometimes, and sometimes billions of dollars. And they do invest in different entities, but they're going to do it through, a different legal entity so that there's not this relationship between them, so that they're inherently tied together, which would increase the risk potentially. So, it's funded through a separate corporation or LLC, which the point is to keep them separate. The profits realized, they're considered carried interest, which is federal capital returns tax rates. That is definitely not something I know much about. I just know that that's, in the plus side, that's a good thing with your tax rates. I'm definitely not a tax attorney. So when you look at what each party brings to the table, this is really kind of it. You're looking at on the left-hand side, the investors, the general partner, they're bringing in the money. The individual fund managers are also bringing in some of the fund direction. And then the portfolio might invest in any number of different companies. So you've got kind of your money in to the private equity fund. The private equity fund invests on the right-hand side to the portfolio, but you've got your fund managers, and that's where your PE firm's coming in, and they're going to have individual fund managers to help provide direction to that and watch and try and make that investment grow to the extent they want it to. This is a more detailed chart. I'm not going to go through it, but it just kind of shows a little more detail, kind of where the money flows. And it's really what happens is you've got your money flowing, and then you also have your expertise flowing also. So that's kind of one piece of it. So John, let's talk about, why do we really have PE investment in healthcare?
Well, and obviously tongue in cheek here, but old Jerry Maguire, show me the money. And look, let's face it, if you're in private equity and you're investing in healthcare, you're doing it for a reason. It's not to lose money. There is the goal, right, from private equity side of the house to invest, to have a return on investment, to make sure that your investors are recovering and getting some positive return there. So why private equity, right? Well, one of the reasons is we look at all the different sectors. Private equity realized pretty quickly, right, they're smart in their investing, that healthcare was leading all sectors in total returns. The other issue is public markets. Well, private equity was seeing a great opportunity in healthcare. Public markets weren't quite giving healthcare companies the same valuations as they were in other industries. So that created some initial opportunity for private equity, right? There just was this difference of opinion in how everyone was viewing the healthcare world. Next was really the private capital options. So companies that back in the day that may have gone and looked for public funding are now starting to explore private options because of this incredibly increased activity by private funding in the healthcare space. And as I mentioned already, the private equity firms were seeing this value in healthcare that in some industries was not being seen. And they saw an opportunity and a willingness to take on risk. So let's go into some areas of healthcare. We think the risk is worth it. We think the return on investment will be worth it. And they were willing to dip their toe in there and saw some great success and returns. Another thing to consider too is just, I'll call it the demographics of healthcare. You've got a growing patient population, right? They're getting older, they're aging. This obviously, when you have an aging patient population, you have people that are living longer, they're having more chronic diseases, illnesses, treatments are necessary, therapeutics, services, products, all those different pieces are coming into play in healthcare. And so in addition to all of that, right, on the patient side and the treatment side, you then have the other side, which is pharma, med device, biotech, right? That all those different industries and segments of healthcare that are all working hard to create new therapies, new devices, and new opportunities to treat this patient population. So again, this is sort of a perfect storm, all things coming together, creating tremendous opportunity in healthcare from an investment perspective. In addition, now you've got the delivery system. I think we can say with some great certainty, there's some things that need to be fixed with our delivery system, right? It's never perfect. There's a lot of area and work for improvement there. It's inefficient in many ways. It's big, it's complicated, it's fragmented. All of that also created opportunity for innovation. It created opportunity for someone to come in, disrupt the market, and develop new opportunities and investment in how services are being provided. And I think we've seen that tremendously over the last couple of years, right, Kim? You think about telemedicine and where, right, from COVID. I mean, telemedicine was something we sort of talked about, And now obviously it's an everyday and regular occurrence. So, right, Kim, I mean, would you say, I think COVID's almost one of the best examples of that change or disruption?
There was a lot of changes during COVID. I think that telemedicine was one of the biggest. I think also when you think about the expanded role in healthcare, there's a lot more end-of-life care than there used to be. So a lot of companies, people understand a little more what hospice is, what the benefits of hospice are. They're trying to shift to home care companies. So you have a lot of innovation in the delivery of care. You have innovation in how it's paid for. I mean, Medicare is, you think of Medicare as being sort of stodgy payment system, but they are looking at, the Medicare, hospital at home program. I mean, there's a lot of money going into trying to figure out the best way to treat the patients, to make sure they get the care they need, and hopefully at a lower cost than what has traditionally been done. So, it's no more just physician, hospital, home, home health. I mean, there are so many different areas of healthcare, and a lot of those do have private equity investment. I think, we talk about one of the last slides, when we talked about who is investing in private equity, I actually sit on the board of a foundation that has over $40 million in the past 3 to 5 years. We set aside, I think it was $2 million or $3 million, and put it in a private equity fund. I think it's interesting to think about that, because we're pretty risk adverse.
Yeah.
We want to make sure that we are being conservative with our money, but at the same time, there is a lot of money to be made in private equity, and it just seemed like a good time to kind of put your toe in the water, and it is tied up for 10 years. So it is a long time, but it was interesting seeing it kind of from like the legal's perspective, and then seeing it on the side of the investor perspective. And, obviously we have fund managers who manage our money and tell us what we should do and bring us opportunities. But we have a group of people who are, very savvy with kind of what's going on in the financial world, and, what the options are, and trying to figure out the best thing we can do for our money. So I think it was just kind of interesting to me to see that on sort of a more personal level.
Sure. No, absolutely. We've talked right about the markets. We've talked about people shifting from public funding to private, to growing aging patient population. What about physicians? Right. When we think about private equity and their increased interest in physician practices, well, it just comes down to something very simple, right? Physicians are driving healthcare. We all know that you go to the doctor's saying, okay, here's your diagnosis, here's a script, here's an order for a device, here's a different therapy, here, let's go get an x-ray, whatever it may be.
Here, you need to be in the hospital. Here, you need, home health care. You need, the physicians really are the drivers. And that's always been the way, that they do drive a lot of the healthcare. But I also think they were one of the first places that private equity made their investments in a big way. It starts with a couple different type of physician practices, and it just keeps growing. It's in the dental space now. It's been in the veterinary space. I think it's not been quite as popular in the veterinary space as it is in some of the others. Dental has been a huge private equity.
Yeah, which candidly, I'm not sure you would have thought that 10, 15 years ago,
No.
right? But these are savvy folks looking, they're sophisticated, they're looking for these opportunities, and they're doing their homework on it. And so physicians, dentists, whoever it may be, they're finding the people, your point, they're driving the bus and they're getting on the bus, right? And so you've got an ability. Let's talk about a little bit what private equity brings to the table, right? So you've got physicians who are driving these healthcare services, not always the best business folks, right? I think we can say that. Sometimes physicians are not always the most savvy business people managing a business. Lawyers aren't always either, by the way, FYI. So, you have that opportunity then for them to come in, and they can infuse with capital. Again, innovation we've talked about. They can bring some management operational tendencies that maybe weren't in place before. So that's sort of there's the push and pull of the private equity investment.
Well, and actually, to be quite honest, the physician's highest and best use is not managing their practice. Their highest and best use is treating the patient. So you can pay somebody else to do some of that. And, that's also when you start to get the private equity investment, because, a lot of physicians are not independent practices anymore. that's something we'll talk about a little bit later too, but there's some issues with that as well.
No, that's a great point. You're right. And so I think getting folks sort of refocused on their highest and best use. And let's talk about the trends, Kim, because we've seen some very interesting trends, right? When we go to the next slide over these last couple of years and what was happening in deal volume and deal flow. 2021, right? We're sort of coming, I mean, technically, I guess we're coming out of COVID at that point. Who would have thunk it, right, Kim, that you would see this kind of uptick in healthcare private equity deals? But boy, an incredible, banner year, it says it right there. Number of deals up 36% from the year before, 380 to 515, just an astounding number. Total disclosed value had more than doubled of those deals to $151 billion.
Well, there was clearly a lot of pent up money capacity.
Yeah. Yes.
That, with COVID, I mean, who knew we could all work remotely? Everybody could work remotely all the time, for basically a whole year.
Mhm.
Almost nobody went in the office. And, it's just, who knew? So many different changes just even in the past 4 years.
Yeah, and it's interesting too, because you're going to see over these next couple of slides, folks, how you see this sort of shifting, right? This sort of ebbed and flow to deals. So again, also in 2021, that year that there was this incredible uptick, there were also a record number of healthcare focused funds that were started, 358, and a total capital of $93 billion was raised. So to your point, Kim, a lot of money that had been kind of sitting dormant, had been under the mattress, waiting to be used, and folks started using it. So we see this great uptick, right? So now 2022 comes around, you see a slight downturn, but it's still the second highest year. So we have to keep that in mind, right? 2021 was so huge. 2022 was still an incredible year. It just had dropped a little bit, to be expected. It was almost sort of a touch of a hangover.
You couldn't keep going at the level you were in 2021. I mean, at some point, you've invested a lot of that money. There's not the pent up capital anymore.
Yeah, and Kim, you do a lot of deals, right? Did you feel it back then? Do you remember looking back, feeling sort of this uptick in activity?
Yeah, there was a lot. I mean, you have public companies who end up going private. At some point they'll probably go public again. But you see a lot of, private equity. I mean, the company that Stephanie works for has private equity investment.
Yeah.
It's kind of everywhere.
No, it definitely is. And as we look, as we sort of see this sort of up and down through 2022, robust, right? Q3 still robust, 96 deals, but you start to see a slowdown. Now let's go to 2023. So now we're sort of, year and a half, 2 years out of the pandemic. Now we see another decrease. However, still seeing a lot of deals in healthcare, right? The overall deal volume started to shrink across all industries in private equity, but healthcare continued to have a lot of deals compared to the other sectors. And again, if we go to the next slide, we see this slow start in 2023, but we start to see this uptick April and May, then it kind of drops again. And so Kim and I were just talking before, as we were sort of doing this discussion, we had done this back sort of the end of 2023, and we were predicting the future. And I think it was pretty consistent across the board. Folks were predicting sort of we were going to come into 2020 at the end of 2023. It was sort of going to kick up in Q4 and then off to the races again. And actually, that's not really what happened. And so the predictions have changed a little bit, right, Kim?
Yeah, they have. I mean, it's still strong, and especially in healthcare. But John, I think you pulled some numbers. So what are we looking at for 24?
I did. Well, and so
halfway through.
Yeah, right. So this is from Bain and Company, folks. So I'm going to read directly from it. But Bain and Company talks about, here's what they said about 2024. They said, sort of halfway through the year, stubborn inflation, high interest rates, and economic uncertainty and labor shortages. And if you're doing work for hospitals, you're feeling the labor shortages or any healthcare service. I've got a lot of clients that are feeling that. And it's taken a toll on private equity markets in 2023, and healthcare private equity was not immune from that. But it talks about the healthcare buyout values had fallen, but despite those challenges, they were still with pre-COVID norms. So again, we've got to think beyond 2021 when things had sort of skyrocketed and go back to what was more the norm. But it does say that there are signals that momentum is picking up, and that's evidenced by rising deal volume relative to 2022 and growing up into 2023, and that buyers and sellers have a vested interest and bridging valuation gaps that they think will make 2024 a year as a catch-up year. So that's where Bain is predicting. So, again, I think what we're seeing is there's opportunity coming, and I know there's a lot of these kind of articles out there, and everyone's sort of watching some of the different major factors and what's going to happen over the next few months. But I think people are all going to see, they all believe 2024, sort of Q3, Q4 is going to pick up.
Well, and you mentioned labor shortages, because that has been a huge deal. Hospitals, nursing homes, home health, all of those, especially with COVID, people didn't want to go into institutions because people got sick and people died. They were testing all the time. And that was sort of a new industry that came up, is these nursing staffing companies, which made it very difficult for some of the healthcare companies to be able to even, kind of stay above water, because the cost for that staffing was so expensive. But so you've got the staffing companies starting up, you've got healthcare companies starting their own nursing school. You've got people starting their own training programs. So it's just interesting to see, when you get kind of push come to shove in different areas, where it causes more growth in other areas, and the ideas that different people have, and the innovation, and the companies, that get started from that. And, just kind of interesting. But
Well, and Kim, just one more thing to add to that, and I think you and I talked about this, and this really resonated with me recently. I had a health system client where we had a payer dispute. We got a bunch of money back, and I may have told you this story where, let's just say it was $500,000, right? So $500,000. And the way the client reacted to getting that money back was not about, oh, we've got money back. It was, now we can hire 5 more nurses. Now we can, right? It was all around staffing and how to care for the patients. And that really struck me.
yeah,
And just, it really resonated how sort of difficult times are with staffing.
well, and it's hard. I mean, I know they've got some of those proposed rules to increase staffing in nursing homes. And, I kind of get that, and I know from the patient side, it seems like nursing home care is really expensive, and it is expensive. I mean, in Nashville, it's about $10,000 a month just for basic nursing care, for your just normal, not skilled care, your institutional nursing home care, probably up 10 to 12 at this point. And that's a lot of money. But there's not a lot of room for increased staffing at that price. So it makes it hard. You're right. If you can get more money and use it for staffing, I don't think nursing homes and hospitals want to necessarily reduce staff. I think that there's a balance and a fine line, and, this whole balancing act they have to use all the time as, how many patients do they have? How many residents they have? What staff do they have to do that? What if they have a certain number of beds empty? How do they get those beds filled? Because at some point, you don't necessarily have to increase staff if you have more beds filled, but you certainly are doing a little better financially if you have more beds filled. So it's interesting to sit in sometimes on some of the board meetings. I work with the CCRC, and just to listen to them talk about the staffing and some of the other issues, and talking about, they've got independent care all the way up to skilled care. And it's just a very interesting dynamic. So, one of the things we are seeing, as you have more money, healthcare regulations follow the money. I mean, there's no big surprise years and years ago when physicians and physician practices started having more MRIs, that you saw a huge increase in the number of MRIs that were ordered. Not that they weren't necessarily medically necessary, but there were just a lot more ordered because you had this new shiny tool that told you a lot of cool stuff. And, Tennessee, for instance, was one of the states that had a ton more physicians that owned imaging equipment, and they had a lot more images ordered. So this is where, your healthcare regulations come in. And so there's a lot more enforcement. So how are we looking at that, and what is next for healthcare with PE? There's more public scrutiny. They're looking at cost, quality, equity, access. I mean, all of those things become very, very important when, and let's be realistic here. I mean, one of the reasons the government is so interested in it, they're not just interested in regulating. They provide, 50% of the money between your federal and state governments for the cost and provision of healthcare. So, the person who provides the cash gets to make the rules. And so that's kind of where we are. That's they get to decide. So, you know, there are going to be new transparency rules. Everyone wants to know kind of where the money's coming from. They want to know who owns the private organizations. One thing that I think one thing that will change is you're going to see more transparency to a certain level in who owns the private organizations. You're still going to see a lot of pushback with the private equity funds as you get farther and farther up the chain, that's not something that they want to disclose or willing to disclose when you have private equity involved in a deal. And if it's something that involves a change of ownership transaction, you know, frequently you're looking at the different states and trying to figure out, okay, how far up the chain do you have to disclose the ownership? Because there's a lot of pushback from the private equity companies, to the point where, to be quite honest, if you're representing the company that's having to disclose the change and there's an attorney on the other side that's representing the private equity company, the lawyer on the other side for the private equity company doesn't even know all the owners all the way up the chain. You know, it's like this double super secret, you know, probably very public figures with a lot of money who just don't want people to know where their money's going. And so that's kind of, you know, a little bit of an issue sometimes with what's going on. So, you know, there's new rules for increased transparency. Some of those in particular in the nursing home world. And one of the reasons we're going to spend some time with nursing homes is not that nursing homes are just so important to the delivery of healthcare, although they are important. It's just that this is one of the first places where they are trying out this increase in transparency. The ownership and disclosure requirements for nursing homes. And I think part of that is because, you know, nursing homes and the real estate used to all be owned by the same company. It didn't take too long, and it's been a long time, but the nursing home and the real estate split because basically then if you have a liability claim, the claim is really against the nursing home and its operators, but they don't own anything. You know, they own the ability to provide care. They're not making so much money. There's just a big pile of money sitting somewhere that somebody can get a hold of, and they're paying to rent the real estate. And the real estate company is a total separate entity that doesn't have anything to do with the provision of care. So, you know, that was kind of the first piece. But Department of HSS now wants a rule that just came into effect in January. They are going to increase the transparency with regard to private equity and the real estate trust ownership in nursing homes. They want to know who owns what. If you're getting Medicare or Medicaid money, and there are very few facilities that do not get Medicare or Medicaid money. Even if you don't get Medicaid, you're probably going to get Medicare because that's who pays for your skilled nursing care. So you're going to have to disclose a lot more about ownership and managerial information than you used to. And if you don't disclose it, that can lead to a False Claims Act violation. So instead of it just being we're going to require you to disclose, we're going to put that big stick there that's going to require you to disclose, because nobody wants a False Claims Act violation. And if you know, here's the even bigger one. If you do provide false or misleading information regarding your ownership interest or the management or control interest, CMS can deny or revoke the Medicare enrollment or subject the provider to fines and or imprisonment. And so those are really the kiss of death for a nursing home, because more than any other provider, they do not have as much private money coming through. You know, it's pretty much all government. So what does the government want? They want every member of the governing body. Okay, that one's probably not so intrusive. The name, the title, the period of service, you know, each officer, director, member, partner, trustee, or managing employee of the facility, you know, your name, title, period of service. I'm actually outside counsel for one, but I'm not technically an officer, director, member, partner, trustee, or managing employee. So I guess that they are not disclosing my name on what they are doing. Hadn't really thought about that till I was looking at this slide right now. I'm like, oh yeah, how does that affect me? So I'm not technically a member of the governing body. I'm just outside counsel. Disclosable parties. And here's where it kind of gets you to. It's not just governing body people, anybody who exercises financial control of a nursing facility. So that could get you to potentially management company. I mean, depending on how much control they have. There's certainly typically, there's a budget that's prepared by the facility, but the management company is part of that budget process and is certainly part of the process to, you know, exercise that control over when the money gets spent. And probably if you have a management company, the administrator of the nursing home is going to be an employee of the management company. So all sorts of disclosure issues at that point. Are you leasing or subleasing the real property? Who is doing that? They want to know where you're getting the property. You know, anybody that has a 5% or total value ownership of the real property. So this is where they're kind of getting back at. It's like, okay, well, you split it apart before. That's great. But now the government really wants to know who that is. Not necessarily for like a service claim liability, but potentially for a liability of any fraud with the facility. I mean, you know, that's where they're going to kind of go back and try and see who all's doing what and what is that doing to the quality of the facility as well. I mean, they even want to know who's providing administrative services, consulting services, accounting services, financial services. I mean, all of that, you know, who's doing the policies or procedures? Do you have somebody doing cash management? Was working with a nursing home not too long ago that had some licensure issues, and part of the problem was the person who was managing it. To be quite honest, I work with the people who won't take over the management, and the manager also owned the company that was doing the cash management services for the facility. So, you know, anywhere they could have their money in the pot, they had their, you know, they had their finger in the pot to do that. So you've got to disclose all that information, and that's information that's subject can be a big deal for the facility. Have to show whether are they a private equity company? Are they a REIT? So here's where, once again, you know, you've got PE in nursing homes also. So, you know, if you collect capital investments from individuals or entities and you purchase a direct or indirect ownership share of a provider, that's what private equity is usually doing. And the REIT has a detailed definition by the Internal Revenue Code. And a lot of the nursing home properties are owned by a REIT. You know, the same thing, I think, you know, some of the prison providers at one point put all the real estate in, the private prison companies put all the real estate into a REIT. So, you know, it's just been something that's been used. And so when we think about all the scrutiny, so, you know, one reason, I mean, government started with the nursing home sector. I mean, I think a lot of that is because that's where majority of the money for the nursing home is coming from, is from the government. So that kind of makes sense. But some of the studies also show that there are quality issues with nursing homes when they have PE investment, that, you know, over 11% are more likely to have a preventable ED visit. You know, almost 9% are more likely to experience a preventable hospitalization. You know, there was a working paper that looked at 18,000 nursing home facilities. So that's a pretty significant number over a 17-year period. And what they looked at said that the PE ownership increased excess mortality, increased the prescription of antipsychotic drugs for residents by 50%. You know, taxpayer spending per resident increased, and there were decreased hours of frontline nursing staffing by 3%. Now, I would say probably part of that, excuse me, the nursing staff may have decreased because the cost of the nursing staff. I don't think it's that they're paying any less for their frontline nursing staff. It's that the cost has increased so much that they have to find some money to continue to operate somewhere. There was a much higher COVID-19 infection rate and a death rate than the statewide averages for PE investment, PE-backed nursing homes. You know, and there's a lot of money. There's a lot of market concentration for PE. You know, 10 owns more than 10% of the nursing home. So kind of a big deal. And, you know, you kind of, the list sort of goes on and on. The staffing decline, the lower star ratings, the, you know, a lot more change of ownership for nursing homes than there are for hospitals. Now, there's also a ton more nursing homes than there are hospitals, but, you know, when there are quality issues, there is more frequently a nursing home ownership change because the existing owner cannot basically get right with their state agency. You know, the state agency is dying to have somebody else come in and operate that facility when the quality gets really bad.
And
So,
Kim, if you don't mind, if I interject, just we have a couple of questions
okay.
before we move on. You talked a lot about transparency, so and you know, more disclosures. Can you share a little bit about how PE firms may be able to focus a bit more on transparency? If you and John have thoughts there, and then we have a couple of questions from the chat as well that we'll ask next.
You know, I think as far as transparency, it's just, you're going to have to disclose a lot of information that you might not have had to in the past. And so that's just something that you need to be aware of. And the government is only going to increase that scrutiny. So I think that you have to be prepared to do that and make sure that you are not, I mean, if it's something that needs to be disclosed, for gosh sakes, don't play hide the ball. I mean, disclose it on, if you need to get owners out, so because they don't want to be disclosed, well, maybe that's what you have to do. Maybe you have to restructure some of the money somehow, but I think that it's, kind of, we said, it's not private anymore. I mean, there are just, and it's not going to be private. I don't see that shifting away anytime soon. I think this has been something that's been building. I think that as you have a lot of consumer advocacy groups who are looking at the issues, and they have a pretty powerful voice, and they're not afraid to use it, and they're not afraid to lobby their legislators. And so I think that's where a lot of this has come from. You said we had a couple more questions.
Yeah, we do. So another question, have either you or John looked at the implications of Corporate Transparency Act reporting requirements on MSO-friendly PC ensitities? Does the CTA require a friendly PC to disclose on its MSO to FinCEN, FINCEN as a beneficial owner?
I have not, Kim. Have you? I have not.
I have not specifically, but I want to say it does require some of that disclosure. I just, for some reason, I feel like I have seen that, and it certainly is another mechanism for disclosure.
Right. And the second question is, are there particular states that should be watched closely as bellwethers for additional scrutiny for enforcement in this space? Specifically, this person's following the progress of CA AB 3129 closely, and that there's heavy legislation scrutiny of MSO-friendly PC arrangements currently in Oregon. And curious if there are any others.
Oregon, California, our states. We're going to talk about some of the scrutiny in just a few more slides, so we'll get to that one in a minute. But certainly from the standpoint, if you're thinking about a fraud standpoint, Florida certainly seems to be a state that always has issues. I mean, it's just some of the stuff. I mean, I have a friend in law school. It's like, you just can't teach stupid. I mean, it's like, seriously, what some of these people do, what are they thinking? I mean, they're going to get caught. I don't know. I just don't get it. It just, I don't know.
I was one of the, when I was at DOJ, I had the opportunity, there was a small group of us that really started that Medicare fraud strike force down in Miami. To Kim's point, just the things you saw were incredible. And there's always some type, I mean, you're always going to have some type of fraud with this much money floating around, right? And getting to the question before that, the concern really around, or sorry, two before that, around the transparency piece. Look, if you're in private equity and you are going to invest in healthcare, you're investing in one of the most highly scrutinized industries in the world, right? I mean, you're talking about healthcare services being provided to patients, and of course, there's going to be a lot of scrutiny and oversight of that.
Vulnerable patient population.
Yeah, and you've got to understand what you're getting yourself into, and one of the things that you sometimes see, and this is a message to anyone out there who does general corporate deal work. Look, if you're doing general corporate deal work and you have a healthcare deal, I mean, for God's sakes, bring in a healthcare lawyer. Too many times we get like people like myself, Kim, others, my job, I really go in and clean up the mess afterwards. That's more of what I do day to day. And you get brought in after the mess, after someone didn't understand Stark law or how Anti-Kickback Statute works. And they did a deal and didn't truly understand it, right? And so, if you're going to play in this space, you've got to be prepared and understand what you're getting yourself into.
Yeah, I mean, it's just healthcare truly, I think, has, if not as many regulations as the tax code, it's pretty close. I mean, IRS, banking, healthcare, those are the industries that you really, need to be careful about. And I think a lot of that is just, banking, because you can rip off the vulnerable patient population, the healthcare, because it is generally, people who are sick are a vulnerable patient population. And because so much of the money is Medicare, so you've got, sick people and old people, and, it's hard. And so I think one of these things that, as John and I said, we do not think necessarily that private equity is bad or all private equity is bad, but it certainly has a PR problem. I'm gonna let John talk a little about some of the headlines because these are real headlines.
Yeah, that's right. And I mean, again, this is not us making these up and picking on private equity. These are real live headlines that we've taken right out of newspapers and different articles. Well, private equity profits, a hospital slowly dies. Obviously
And that's
there's
a
a
lot,
question about.
but we see so many rural hospitals who struggle to remain relevant and to remain open. It's just a hard thing.
Yeah, and just 2 days ago, Forbes had a big article on private equity and healthcare. And the article headline is private equity a villain in healthcare? I mean, these are pretty salacious. And this is creating some of that PR issue for private equity and healthcare. And also, by the way, driving some of that, increased scrutiny that they're facing. And, someone asked the question about states to watch. Well, New York, New York, as we recall, right, was the epicenter to COVID. All of the deaths and quality of care issues in nursing homes and skilled nursing facilities during that time period, we've seen a tremendous uptick in New York from at the state level in terms of enforcement and oversight and putting in place different types of essentially monitorships was something you didn't really see before. So you're seeing a lot more activity where there might be an enforcement action, but then there's some type of add-on requiring a certain amount of monitoring, reporting, and compliance after the fact.
Yeah, an ongoing issue. I like this one too. Like there was a U.S. senator who, didn't like Ascension. And the bad thing it said was it was operating like a private equity fund. It wasn't really acting like a nonprofit hospital system should act. What they were doing looked like they were a private equity fund. So, once again, bad statistics, patients receiving care at PE-owned facilities, increase in hospital-acquired conditions that were considered preventable, falls, double-site surgical infections, so central line infections. Some of these things, there are increases, even though there are fewer surgeries performed or fewer central lines in patients. So, higher cost and reduced staffing levels for hospitals. And I will say, I think a lot of the reduced staffing levels because the costs are so much higher and it's really hard, to operate, and higher death rates in nursing homes. I think COVID really, it just swept through some nursing homes. The first days of COVID, there was some, nursing home outside Nashville that, you saw the ambulances there. They had every ambulance company there discharging every patient to somewhere else because there had been just a huge COVID outbreak. And you had to get everybody isolated at another facility. But just the measures that nursing homes took, and, I'm not sure the general public really realized it, but if you had a family member in a nursing home, you didn't see them like for a year. You were not allowed to go in the nursing home and see them. And that was because of, government regulations. And, a lot of people died during that time. Maybe they would have died anyway, whether they got COVID or not. But if you take a vulnerable patient population and they don't have any, family members who are able to see them, or maybe FaceTime through a window, which is not the best, you're not getting any real touches with the family member, they do go downhill. They go downhill faster than if you were able to visit them. So, there were a lot of higher death rates during that time period. So, John,
All right, let's turn to that.
We got more and more.
Yeah, no, and this again is just another example. Right now, it gets to the Hill. So you have the Hill showing interest in this, and now you got politics involved. So there's going to be a lot of activity. December 7, 2023. At this point in time, the Senate Budget Committee investigates some of this hospital ownership, right, issues that they're seeing. And it's private equity's ownership of different health systems. What they're seeing, at least claiming to see, and what created this issue and concern was staffing reductions, which we've talked about, healthcare, the quality of the care, the assets like being stripped away from these different entities, right? Sort of reducing costs, selling off assets, trying to drive up profits, drive up revenue.
And I think that's a really big one, with stripping of the assets the government really is not happy about, because you might have taken a hospital that is kind of struggling to begin with. It sells really its only real asset, which is the real estate, to somebody else. and then it has to pay rent at a rate that's too high for it to afford. And, I'm not saying this happens every time, but this is happening, and that's why it's been an issue and why the government's looking at it.
Yeah, and it adds to this PR issue, right? And the scrutiny, because the messaging starts to become, what we're seeing is profits becoming more important than patient care. And facilities are closing, right? Impacting access to care. So when you think about a community, right, that if you're in a community, you want to make sure that folks have access to care and that care is a high quality. And that's what you're seeing. Some of the biggest criticisms against private equity being is that they're starting to remove some of those opportunities for access and quality. And then this just final note here, Kim, right, that 90% of healthcare companies classified as financially distressed. And this statistic blew my mind, right? Financially distressed are PE owned. And that absolutely surprised me when I saw that. So,
I mean, I would say, we're not really trying to bash PE because we do think it has some benefits, which we will get to in a minute. I know we've had like quite a bit of time about PE, the bad, evil villain, devil incarnate kind of type thing. But these are statistics that people have gathered. And, they didn't just make up these numbers. I mean, and they're generally creditable companies that are looking at these, metrics for different healthcare companies, and they're not looking good, when they're PE owned. I mean, the fact that most of the not most, the overwhelming majority of healthcare companies that are financially distressed are PE owned. I mean, 90%, that's like almost 100%, 92%, I would say pretty much 100%, but 90%, you're getting pretty close.
Yeah, and it's really interesting too, right? Because again, we keep saying we're not here to bash, which is true, we're not. I mean, what we're laying is that groundwork and that background as to why we've seen this increased scrutiny, increased oversight, and more enforcement actions than we've ever seen before in private equity and healthcare deals.
Yeah,
as we go to the
that's
next,
really it. That's why, if anybody says, why do you have the increased scrutiny? It's like, this is it. It's kind of like, I remember one time I was talking to a physician group, and it's like, well, why do you think the government, this was a long time ago, why do you think the government has Stark and the anti-kickback? And what I wanted to say was, and that physician had a particularly bad day, I still give him a hard time about it today, but it's like, you know what? If the doctors had monitored themselves, you might not have ever had some of these laws and the scrutiny that you had. And, I know that Pete Stark said before he passed away, he wished he'd never passed the Stark law, but it's still alive and well and is keeping going. So.
And before we move on, we do have sorry, John, before we move on,
please.
Question, can you comment on the difference between PE in specialty medical practices versus PE in healthcare facilities? The comment goes on to say, my high-end specialist clients report that PE largely leaves them alone to practice as they always have. Certainly there's less interference in those who sell out to hospitals.
I think that PE investment, a lot of specialty practices, I think that that's true. And I think it depends on what you're negotiating on the front end and what kind of a PE entity you're going with. Let me say, it leaves them alone to practice medicine. It is not going to interfere in the practice of medicine. It can't interfere in the practice of medicine. That's why you have the corporate practice of medicine laws to begin with, so that, the money can't really control what they're doing for the practice. It's a little bit different with the hospital because there's not that direct nexus with the provisional care and the physician. With the hospital, it's more a few steps removed from the actual provision of care, the changes that are being made. I think with the physician practice, and the PE investment is more in specialty practices than in others, like gastro is a big one. Oncology has been a big one now, like we said, dental, those are some of the big ones. Anesthesia. They do more the management of the practice and not the care provided by the practice. So yes, when the physicians say they're primarily left alone to practice the way they've always practiced, yes, their medical practice should not change if it's PE owned. That's not always true, and that's when you get PE companies in trouble, and we've got a couple examples of that later on also.
And then just one other comment before we move on. a question about the research paper you referenced on PE and nursing homes. Is it the NBER working paper 28474? If not, can you share that?
I'll have to go back and look, but we can figure that out. If somebody wants to email me, we can find that.
Yeah. All right, terrific. Well, thank you for your questions, everybody, and
Those
like
are
the whole
helpful.
yeah, very helpful to talk through this and understand some of the issues or questions you have out there. Again, really where we started was the background and foundation to where we get to this slide, which is, well, you can't be under the radar anymore, right? Or you can't be off the radar, under the radar, however you want to look at it. Private equity is going to face additional scrutiny today, more than it's ever seen before. We go to our next slide, Kim. It's our evil eye watching you. Enforcement agencies are watching everything you do. And if we go to the next slide, really kind of turn to what's happening at the state level. So we all know the federal government, right, has been very focused on healthcare and on the transactions and deals. There's $119 million, $119.5 million threshold, right, that requires or triggers notification. But what have the states been doing? And states started to realize there's a whole bunch of transactions that are taking place that are private equity investments, private equity deals, however you want to state it, that are under that number. And they were, again, flying under the radar. They were under the radar then at that point. And states really became concerned about the access to care for their community members, the type of care, the quality of care, and frankly, just this issue of transparency, right? Who actually owns the entity and who's making the decisions? And so they started to dig more deeper. And now what we're seeing is states becoming much more active, right? They're enacting legislation. States are requiring certain deals to now are going to have advance closing notice. The state attorney general is going to have the ability to step in to review it, to stop it, to create some additional conditions. They need to make sure that it's meeting the needs of the community. And if you think about some of the hot topics today and issues today, fertility services, healthcare equity, all of that has to be satisfied. So states are becoming much more active. And I feel like, Kim, every week there's sort of another state passing another piece of legislation involving, this access to information and transparency and ownership.
There are. And, frankly, when you mention the fertility services, there's a lot of PE money in women's healthcare services companies. I mean, sometimes these companies are really just either they're taking a particular piece of healthcare for women and splitting it out, or they're taking all of it and combining it together. So there's different ways that PE is involved, but that's just a huge sector of the population, huge amount of money that goes toward the women's health services. I think it's also important to note out that this is different from a lot of states already have AG approval for, if a for-profit healthcare system is going to take over all or substantially all nonprofit health system, that's going to be subject to AG scrutiny almost, as far as I know, most of the states that we've done things with, and that is truly an approval process. And, it's a pretty lengthy process as far as information that has to be gathered and provided. But this is different because this is just, more scrutiny, more, gives the state agency power to block the transaction in a lot of states. But it's also important to look at, and it gives them oversight authority post-closing. The New York we were mentioning, when you talk about states that you have to be careful of, New York is definitely one. John, I'll let you go through it a little bit more, but it is one that is really kind of on the leading edge of this whole trend with the states taking notice.
Yeah, and I don't think in some ways this is new in New York in terms of their ability to really focus in on a healthcare issue that affects Medicare, Medicaid, whatever it may be. I mean, really Medicaid when it comes to New York. They've always had a very aggressive posture at the state AG level and have been, to your point, right, sort of on the cutting edge. And this is requiring now 30 days notice for material transactions. There's a very long definition of what is included in a material transaction. There can be monetary penalties if you don't comply. And again, you're seeing a number of other states go in this direction, right? It doesn't matter the dollar value. It really matters, hey, what's this transaction about? What's it look like? And here we list a variety of different states that have passed similar legislation. Starting with California, again, another place that really tends to focus in on transparency and wanting to understand who's doing business where and what they're doing. And
Well,
if
and
we go to,
California has a bill right now, 3129, and that would give the AG authority to block private equity firms' moves into healthcare industry. And, they're looking at it as a potential model for other states. And they see it as limiting consolidation, which they see potentially as a bad thing, and protecting patient care. That's, you look at these headlines, they've seen supposedly that if you have consolidation, that reduces the patient care. That's kind of a big thing. So, given the AG, some of these are just not an approval process, they're a notice process. And
that's right.
that makes a really big difference. And some of them also, it's, Massachusetts, material change transactions. That's pretty broad. That's bigger than, Nevada material change of group practices, and if it results in a practice provider greater than 50% of the services in the market. So, and really a part of this all is antitrust concern also. That's what your Hart-Scott-Rodino is. I think we kind of forgot to mention, let's go back to the real basics. Why are we doing all this? Yeah. This is why, because they want to make sure that as private equity puts its money in, that it's not controlling things to the detriment of patient care. And so, there are a lot of states, California, Oregon's one of those. And
I think on the next slide, right, we mentioned Oregon there, and I know you're right. I'm laughing.
Right.
Yeah, I'm laughing, Kim, because I was thinking the same thing. We've spent a lot of time talking about access to care, quality of care, but you're right, competition is a huge part of why they want to understand what's happening.
It's like, duh, yeah, I forgot to mention that one. Sorry about that, y'all. It's kind of the big thing. New Mexico is one now that also has, something that's pending, and it says consumer advocates want more transparency and ways for community members to weigh in. So that's also part of this, like your AG process. If you have a for-profit health system purchasing and, all or substantially all the assets of a nonprofit health system, that is subject to public comment. I mean, you have to, part of the process is you publish in a newspaper, basically of general circulation in the county where the affected hospital is. And I'm speaking as to Tennessee particularly, but it's when I've seen other states, it's pretty similar to that. And the public is given a chance to weigh in. If they think it's a bad thing, they get an opportunity to talk about why they think it's a bad thing. And the AG's office really does look at this. One of the things that's really important about all these examples as well is, what is the timing? Is it a 30-day notice? Is it a 60-day notice? Is it a 90-day notice? If you're representing a company that's going to go through a change of owner, how does this affect the timing of your transaction? I think that that's something that's really important to think about, that, is this now going to be the long pole rather than a change of ownership with your state licensing agency or Medicare or Medicaid notice? What are we looking at, and how does this affect? And if it's, states a lot of times for change of ownership is more a notice provision. It's not an approval provision. So that's the distinction also. Are these a notice provision? Or are they approval process? And I think that makes a big difference. And a lot of these do affect, I think, Stephanie, what you had mentioned before, a lot of these do really affect PE and physician practices, and are partly why they've been done, to get that, to see what's going on with the consolidation. So, let's talk about some. And Stephanie, are we okay on time?
Yeah, we have about 25 more minutes, but before we move on, we do have another comment and a question. So questions, or one question, very helpful answer on the practice facility distinction. A related question: are you seeing enforcement action concerning hospitals that are trying to keep up with PE? For example, PE company A is offering a practice $10 million per physician for its practice, while hospital B is offering a guaranteed salary package worth roughly the same amount per physician, meaning that everyone is being paid multiple of MGMA.
I think that's, let me get to that when we talk about some of these regulatory and compliance issues, but short answer is, PE companies can do things hospitals can't sometimes because there's no referral relationship. So probably the short answer is that may not be a good thing for the hospital if that's not fair market value. The PE firm is not quite, it's not as big a deal because there's no referral relationship. So that's, yes, there can be a difference in what they're doing. And I would say that very few hospitals can actually offer the same amount that a private equity company can. So actually, I think that probably answers and addresses the question. So I guess the piece is, yeah, you still have some of the regulatory and compliance issues in PE deals. Probably the biggest with your physician practices is going to be your MSO, your corporate practice of medicine, fee splitting, licensure, payers, all these same things. Like any deal, you go through your list. But to some extent, they're a little bit different for PE firms than they are for other transactions because you don't have as many of the increased risk with the PE transaction that you do when there's a referral relationship, like with the hospital. So corporate practice of medicine, another state law thing, I'm going to do a plug for HLA. HLA has just released, I think it's the 3rd edition of their corporate practice of medicine book. If y'all have never looked at any of the books that HLA publishes, they are fabulous resources. They are very well done. Attorneys like to be part of these books because it gets your name in the book. And so you have a lot of people who are really good at what they do who donate their time to get the book published. And they are just fabulous resources. So anyway, my little plug for HLA for the corporate practice of medicine book. It's a big deal, especially with the PE, if you have a captive PC, common model, the designated physician owns the physician services entity. It's the only owner. The rest of the physicians are employees. It can be replaced by a physician at any time if the PE-backed management company wants them to be replaced. So there's a lot of specific contracts and issues when you're setting these up. California, that's a big deal in California. They're not real happy campers with the captive PC model at this point. I guess that's one way to put it. The Envision lawsuit, KKR and Envision went through bankruptcy. So it definitely was not a good thing for them. But the thought was that, their actions violated corporate practice of medicine because the non-licensed entity was controlling physicians' practice of medicine. Which physicians were hired, their work hours, the staffing levels, number of patient encounters, and which physicians would be terminated. Now, I will say that is not uncommon when you have an MSO. None of that really is the actual clinical practice of medicine. Let me put it that way. And this is pretty common in most states where you have a corporate practice of medicine, what we call kind of a friendly PC model that has been recognized and accepted. Those are all the types of things that a management company would work on. They certainly, I would say physicians probably have input in a lot of these things. The work hours, they probably have input, but a lot of those things are pretty specific to the actual management of the practice and not the clinical practice itself. And, California did not like that. So California was not happy about it. As we said before, antitrust is a big deal now with that. There are stronger FTC, DOJ guidelines for healthcare deals. They felt like those are needed. That's the scrutiny. The FTC, that scrutiny is not decreasing. I think it's only going to increase. They're going to take their time more. A lot of deals that before might not have been a problem are now going to be seen as a problem and at least reviewed, whereas before they might have been so totally under the radar that nobody cared what was going on. I will say, going back to the question that talked about where do we see kind of like a lot of fraud, and we mentioned, Florida, that's one. When you're talking to clients about, it's always like a risk analysis, how risky do you think this is? And that's one of the things that you're looking at and advising them on is, and luckily I don't usually have people who ask me to do something that I have to get my really big hat on and say, basically you're the one going to be wearing orange, not me, because I'm not going to tell you can do that. I'm going to tell you that is extremely risky, but at the end of the day, it's your risk and not mine. So, as long as you have these things, I guess the point is there's always going to be a ton of low-hanging fruit where people do the stupidest things that are so clearly wrong and egregious that sometimes if you're kind of like just barely a hair on the line, that's going to be something that's probably fairly low risk. And you're probably not going to have to call John because nobody's going to care about that when you have people making millions of dollars doing really, really stupid things. Here's one we talked about, anesthesia. there was an FTC suit against not only the physician practice, but also the PE fund. And, basically antitrust. The anesthesia practices in Texas, they acquired them, they monopolized the market, and that drove up the prices for patients and generally the profits. And that's, seen obviously as a bad thing in healthcare. Now, the interesting thing about that is, well, there are all these, well, let me just go back to talk about this for just a minute. So the suit against Wells Carson was dropped. So, but the suit against Anesthesia Partners is still going strong. So that's kind of a different piece of it. So when you think about the PE deals and the Stark and anti-kickback issues, the real things that get into that are, and what the real issue kind of, I think John talked about a little bit before too, if you're not used to doing healthcare deals, for gosh sakes, please, please, please get a healthcare lawyer. I suspect that everybody on this call is truly a healthcare lawyer. So, you know exactly what I'm talking about. And a big thing also is the risk tolerance of the parties can be really different. I think I'm fairly risk adverse. I do also try to be reasonable in what people can do and, try to take advice that way. I think a lot of that is I've been practicing a long time. I've seen a lot of different things. I've seen the purchase of physician practices, the sale of physician practices, now the back to purchase of physician practices. So, and there are some common things in your PE deals, your management fees, your earnouts, your roll forward to equity, what are you paying for marketing and advertising? All of these are specific regulatory concerns. So something to really be looking at. And the really big deal is what's common in other industries, you can't always do in healthcare. And if you don't have healthcare expertise, that makes a big difference because you don't understand why, like, why can't I do that? That makes perfect sense. It's like, well, it makes perfect sense from a business standpoint that you want to make more money by paying people to refer their patients to you. And that, of course, is the most egregious situation, but you just can't do that in healthcare. So I'm gonna let John talk a little bit more about where that bullseye is focused and, pretty clear what they're looking at.
And John, before we move on, just a couple of questions. One, thoughts on insurers' plan to buy up medical practices? Any possibility of more regulation regarding this move, or to make corporate practice of medicine include blocks to insurers?
Interesting question. Kim, I'll let you talk about that piece. I mean, what I will say is, it is amazing how much we are seeing payers purchasing providers, and where it used to be, right, everything, there was sort of that line in the middle, and it was provider on one side, payer on the other, and boy, it's getting muddied out there now, and it's affecting us too in the private sector, right, where you might have a practice that's very provider focused, you might have a practice that's very payer focused. And now, how do you deal with that? And so we are seeing a lot of that, and it wouldn't shock me. I'll just speak from my gut, Kim. It wouldn't shock me to see an increased, a very deliberate increased focus on the payers owning the providers.
You still have to follow all the corporate practice of medicine laws. There are a lot of payers who've gotten in trouble with what they've done and how they've operated, because it is a fine line. It's definitely a balancing act. And it just, if you think about it from a very high level, it just seems intuitive that your payers shouldn't own the practices that are ordering their services, ordering services that they then pay for. But as long as certain, I guess, guidelines are in place, certain guardrails are in place, then it's okay. But it is something that is definitely a balancing act, and you have to be really careful about if you're the payer owning and operating. But they own and operate a ton of physician practices. And part of that is physicians don't want to own their own practice anymore, a lot of them. They don't want the hassle of the business side of it.
Right. Thank you.
All right. Kim, why don't we go to the next slide? And I'm watching the clock here carefully.
Yeah.
We've talked about a bunch of this, but really, what are enforcement agencies focusing on, right? When they think about private equity, and we've talked a ton about transparency, competition, quality of care, access to care. What they're really looking at, though, is how involved is the private equity firm? How involved are the investors? How involved are they in management and day-to-day operations? What role are they playing, the private equity fund? What role is it playing in decision-making day to day? And as you can imagine, the more involved you are as a private equity fund, the more risk. right? Because you can't say, oh, I didn't know about that, or, oh, geez, I wasn't aware of that. I mean, if you're in there making decisions that are impactful, you're going to have more risk. And so the False Claims Act has been the Department of Justice's most effective tool in its toolbox for many, many years, right? And I'm assuming everyone here is familiar. You can have a whistleblower come forward, or a relator. They can file a complaint. Government has to investigate it. The relator can receive a reward if the government intervenes and it's settled. And over the last few years, we've seen this uptick trend of False Claims Act activity in these particular cases. So when you think about the risk of what that means for the private equity firm and the portfolio company, can be pretty significant. The settlements can be enormous. Penalty, if you think about what a False Claims Act case can bring, you've got treble damages plus a per claim penalty that's up in the high 20,000. I think it's over 27,000 now, 28,000. You've got defense fees, just your legal defense fees. You might also have a public relations firm that's helping. You've got impact to your reputation. So these exposures, both at the federal level and the state level, can be really significant, expensive, disruptive, all that. And it's going to come down to the control and involvement that you have in the management of that portfolio company. And maybe we can take a look at a couple examples here. As we go forward, we're going to have risks, right? It is False Claims Act, investigate, obviously criminal, civil, healthcare fraud and abuse. Are you violating something that's going to trigger a False Claims Act penalty? You've got the risk also of exclusion potentially, right? Administrative type remedies that can take place. HHS OIG could step in with DOJ. They're going to work the case together typically anyways. Monetary damages. And so best practices, and this is going to be the mantra, due diligence, due diligence, due diligence, right? You have to do appropriate due diligence when you're considering an investment in a portfolio company. And we're going to go back to get people who know what they're doing. People who understand healthcare, people who work in healthcare, lawyers that understand the healthcare laws and risks and compliance risks to advise you through that deal. Because you're going to inherit a real problem if you're not careful. And it could wipe out a significant investment. And just trying to find, compliance, a way to put in place compliance, if it's not there, that's going to be seamless and quick and up and running. So all of those are going to play a big role in sort of, hey, is there risk? If there is risk, what are the best practices to try to minimize that risk? If we go to the next slide, Kim. Just a couple of cases here. We list these. I'm not going to go through all of them, but what's interesting with these cases is you see not just the private equity firm, but you're also seeing executives and companies get hit. I'm going to go right at the top here, the diabetic care. So here you have the company and two executives, so two individuals, and the PE firm had to pay a $21 million settlement to resolve allegations of kickbacks to marketers for what was alleged to be medically unnecessary pain creams. I think we all remember the wonderful pain creams from back in the day, and those cases that sort of sprung up with the Department of Justice. And then if you look at the bottom here, South Bay Mental Health Center, again, you've got the PE firm paying $19 million, almost $20 million, but also two individual officers agreeing to pay another $5 million. And this involved allegations that this mental health center was using unlicensed and unqualified workers and counselors to provide what was considered to be inadequate supervision and inadequate care. And then I'm going to quote here this particular case, Alliance family, because again, Alliance was the company that agreed to pay, the portfolio company agreed to pay $13.5 million and another $480,000 to the state Medicaid program. So we've got federal and state. This concerned allegations of kickbacks. And then Anchor Holdings, which was the private equity firm, agreed to pay another $1.8 million and then $65,000 to Medicaid. So $1.8 to the federal government, $65 to Medicaid. Again, this involved allegations of false billings and kickbacks. And my old colleague and acquaintance and friend from DOJ, who was the acting U.S. Attorney, Jennifer Lowry at the time, provided this quote. I'll let her know I quoted her here. The settlement should put healthcare providers on notice that we will hold accountable those who seek to profit by pursuing kickbacks and other improper billing schemes. And so the key point here is those who seek to profit. That gets to the point of transparency, that gets to why they're trying to drill down to understand ownership and understand decision makers, because it's not just they're not going to stop at the middle level. They want to go above.
And profit is not bad. I mean, we're not saying profit is bad. We're not saying PE shouldn't make a profit. But the point is that if you're doing it by pursuing kickbacks and other improper billing schemes, that's a no-no. That is just something you're not allowed to do.
Yeah, terrific point, Kim. And you're right. I mean, we have that debate a lot with DOJ, right? Just because someone's making, it's not illegal to make money. It's not illegal to
Right,
be a well-run business and be profitable. There's nothing wrong with that. It's how you're doing it.
right, right. Another investigation, I mean, I think what was interesting about this one was it was a taxpayer-funded program initially. It was supposed to help the sickest and poorest seniors live comfortably in their communities, not nursing home and hospital. The former head of Medicare and Medicaid, who partnered a PR firm at this point, he orchestrated a takeover of this nonprofit taxpayer-funded program into a for-profit company and the largest program at the time. And then it was accused of denying patient services and drugs, causing chronic illnesses to get work. The lawsuit ended up dismissed, but now they're investigating the company for the same fraud allegations. So I think it just shows bad facts and adverse outcomes are a problem. So we kind of want to get to just a few kind of, I guess, tips and tricks. And one of the things I think we talked about, Stephanie, I think you can maybe tell us a little bit on this one. So, lawyers are not very tech savvy. That is definitely not my highest and best use either. I mean, as far as computers, we have a 24/7 help desk. They are fabulous, answer your questions immediately, generally no more than 30 seconds. So I will not be the person leading the charge on AI or anything else along those lines, but I know that, there are technologies. And what technologies do y'all have that a PE firm could use during the diligence process?
Sure. So I think, there's really two technologies that we see largely used and that we support in relation to diligence and maintaining compliance. One are data rooms. Obviously, you want to have the ability to upload the information. They provide, those online repositories for secure access of documents and data, so that you're making, as you're going out and you're investing in these organizations, you're doing your diligence to ensure you're maintaining compliance. So of course, viewing that information. And second, really your contract lifecycle management solution can support a lot of this, such as ours. They have the ability to streamline and give visibility and transparency into the documents, into the data. You can utilize analytics, insights, in some cases AI, to make smart decisions around, one, are you entering into these investments appropriately? Are you performing due diligence? Are you putting processes in place to mitigate risk of non-compliance? Are you providing that transparency? So if there are questions around why the deal was entered into, and that you have those answers. Additionally, I'll just add that on the post-diligence side, giving visibility and gaining that visibility into those contracts and that data allows you to identify opportunities for performance metrics, cost savings, where you have an opportunity to renegotiate certain contracts. PE groups are, as you all have talked about, they're wanting to invest to get a return. And so oftentimes that comes with identification of ways that you can provide some immediate cost savings and ROI on that investment. And your CLM solutions can help you gain insights there.
That's good. That's very helpful. So moving on just a little bit to kind of some of our sort of hopeful, helpful hints. And we do appreciate all of y'all who have been on the call. I know that there have been several times when the code for CLE has popped up in the chat box. So hopefully y'all have seen those when it's come up. So really, I think a big thing is you got to understand the healthcare industry. Okay. So if you're a company that has never been involved in the healthcare industry, make sure somebody tells you that it's different than anything else. Hopefully you will at least know there's enough headlines these days on healthcare and regulation that hopefully you understand you need to have somebody who knows what they're doing when they're working on it. If there are any potential compliance problems, really identify those just as early as you possibly can and try to take care of those. You don't want those hanging over as you're trying to go through your deal. Cost cutting, this is not the time to cost cut with your compliance processes. That is never a good idea. It is when all sorts of things can go wrong. And certainly anything you spend for compliance processes, if you have an issue, you have wiped out way more than what you would have spent for your compliance process. So, keep looking at it, evaluate it. Is it appropriate? Are you identifying what you need to identify? And make sure that you're changing if it needs to be changed. The regulations don't always change, but sometimes the interpretation of those regulations changes. Or is there new regulations that come into place? Is your compliance program still appropriate? Make sure that you're intentional about involvement with portfolio companies. Balance the benefits to growth and performance against the potential enforcement exposure. What kind of company is it? If it's a company that has, huge rates of return, really look at it before you do anything with it. You want to make sure it's not some huge hidden risk that you might not have done. Your due diligence, what did you find out? Did you identify issues? How did you handle those issues? Those are all things the government's going to look at if they look at you later on after the fact. How did you evaluate the risk? What did your documents say? Were there, any emails out there that said bad things so that you have a bunch of bad facts? If you have bad facts, how are you going to handle them? You don't want to say, oh, well, I'm hoping nobody will see this email later on. What are you going to put in place so that you don't have anything like that later on? And what are you going to put in place that might need to mitigate the risk that came up with that? Has the PE firm, have they been hands off? Are they the driver? What is their involvement? Because as John was talking about earlier, if your PE firm is really the one doing everything and making all the decisions, especially those about patient care, that's not necessarily a good fact, and certainly not going to be a good fact if something comes up that's wrong. Make sure you're doing ongoing monitoring or following up. Your compliance program and plan is really important. So, John, what are some things they can do to limit risk?
Well, we talked about due diligence, right? Most important in a deal, any deal, is doing your due diligence, understanding healthcare, understanding the risks, and make sure you're checking those things out to ensure they're minimized. And then compliance, that has to be ongoing. And compliance has become not something that, well, you should have it. It's a must-have today, an effective compliance program, and one where you're following the sentencing guidelines, 7 elements, all the good things that you need in a compliance program. And then finally, I would think, understanding what's the involvement going to be of this private equity firm? What's the extent of the involvement, the scope, the breadth, the objectives of the PE firm and the company itself, and making sure that you're doing everything in a way that's, again, minimizing risk for the firm, the private equity firm, I should say, as well as the portfolio company.
I agree. There are experts out there for everything. It might be a lawyer, it might be a consultant, but you need somebody with relevant healthcare regulatory expertise to do the due diligence. You need somebody, you certainly have to have somebody who directs it. Whether somebody else without the best healthcare regulatory experience is looking at the documents and identifying A, B, and C, the fact that you knew you were supposed to identify A, B, and C, that's really what the important piece is. And that somebody has appropriately done that and identified if there's any issues. If there were compliance concerns that were raised during the transaction, either self-disclose during the transaction, require the company to make a self-disclosure, take corrective action as soon as possible as a condition of the closing, or if it's something that you're going to address after closing. And that, I think, also depends on what did you find? How big a deal was the compliance concern? Is it something that should be subject to self-disclosure? And if it is something to self-disclosure, it can happen after closing. It can happen prior to closing. You just want to make sure that it's been taken care of. Make sure that the portfolio companies have adequate resources to make sure they have effective compliance programs. Compliance. If you don't have an effective compliance program, so you're not doing any kind of auditing to know whether appropriate practices have been followed, that's a big red flag. If you're just out there all, kind of fat, dumb, and happy and have no clue what you're doing, government loves you. If you've made a bunch of money or gotten a bunch of money from the government, they are going to take every penny back and then some. You can't just be an ostrich, put your head in the sand and ignore things. You can't say, oh, I didn't know. You're supposed to know. You kind of have to know if you're going to be operating a healthcare company. So make sure that you've got that effective compliance program. And, if you're offering any kind of incentives or any types of payments, make sure they meet all the appropriate regulatory laws. Do not have any appropriate money flows. that's going to be also a huge red flag. I mean, there's just not some of those things you just can't fix almost. You almost just have to, if you discover it, you got to basically lay down on your sword and beg for whatever leniency you might be able to get, which is probably not a whole lot sometimes. Now, if you've had that effective compliance program and something inadvertently went wrong, that's a whole lot better than if you just weren't paying attention and not following anything. But things can go wrong. The government recognizes that. They don't want to make a big deal about small things. You know, we're hearing a lot at other conferences when the government is speaking that, I mean, I won't say they're going to be your friend, but they're not necessarily your enemy either. I think that's the big piece of it. They are not always out to get the poor provider. You know, first of all, the providers aren't always poor providers. So that's another piece of it, but they're not always, the government's not just always out to get you.
Well, and Kim, on that point, I would just add, again, it's going to be a lot easier doing these things on the front end than getting pulled in and having to explain why you didn't do effective due diligence, why you don't have a compliance program, or you didn't put one in place, right? That was effective. So they're going to ask those questions. I've been on both sides of these, and those are the questions you're going to be asked if this goes sideways.
Yeah,
I think we're at time.
We're at time. So any final thoughts?
Him said it best: compliance, compliance, compliance. Kim, I'll hand it back to you.
Yeah. Oversight, compliance. Look at your investors. Make sure everybody knows what healthcare. Continue appropriate operation of the companies. Yeah.
Right. Well, thank you both so much for joining. Thank you to our audience that attended. I was thrilled to have an opportunity to moderate the discussion, and I hope everyone has a wonderful day. CLE code is in the chat. Additionally, a recording and the slides will be sent out within the next couple of days. So thank you.
Great.
Thank you.
Thanks, everybody. Thank you.
Bye-bye.